Hello everyone. So we're changing the focus a little bit now to try to predict what's happening in omalizumab and cyclosporine treated patients, and after that Chris will tell us about what to do in non-responding patients. So we hypothesized several types of responders to at least omalizumab, and these different scenarios, those are the ones that we are desperately trying to grasp different clinical serological markers to try to predict, so we can maybe personalize treatment a little bit more than we are able today. So there are a bunch of biomarkers, and I guess that biomarkers is really a broad term. It includes a bunch of clinical characteristics of the patients. It also includes measurable traits and biological traits also that are a little more close to the pathophysiological process itself. So if you don't listen to anything else, just focus on this slide. This is maybe the most important slide of the presentation. And it essentially says that we have kind of opposing expectations of what to see in omalizumab and cyclosporine treated patient based on biomarkers. So if you have autoimmunity or positive autoimmune tests, that's negative in terms of your expectation for omalizumab, but it may open a window for cyclosporine. For IgE, serum total IgE, you would like it to be high if you are treating with omalizumab, but conversely, it will be low if you want effect with cyclosporine. And then D-dimer, that's the same pattern. This review beautifully reviews all the evidence for biomarkers in cyclosporine, and up until the abstract book came out, there was no systematic review on omalizumab and biomarkers for predicting response, but there's actually a poster, I think, so a systematic review is on the way, so you'll be able to read this in more detail. Once that, the first time we did this study, we actually thought that if you had been treated with immunosuppressants of the old-fashioned type, cyclosporine, azathioprine, you belong to a particularly severe and recalcitrant group. But now that we see this opposing mechanisms of action of cyclosporine and omalizumab, this essentially tells us that maybe this is evidence that if you respond to cyclosporine, you won't respond to omalizumab, and the other way around. Just going through some of the results that highlight these most established biomarkers. Again, this is a study of the histamine release, the basophil histamine release test. The response to omalizumab is much greater if the test is negative. And this is also true for the ASST test. And then another result emerges down at the bottom red bracket, where we see the influence of serum total IgE, that the low level of serum total IgE is a predictor of poor response to omalizumab. And also, if you don't see an increase in IgE during treatment, that also signals that you are in trouble when treating with omalizumab. This study also highlights this phenomenon that IgE can be used as predictor. So, and this is the D-dimer. This group later also refuted their findings. So I guess it's a little tricky whether D-dimer is a useful predictor. Literature is a little conflicting in this area. So we desperately want some more urticaria-specific biomarkers. One proposal here is the eosinophil count. So low eosinophil count at baseline is associated with non-response. This is something that is also visualized in a poster at this meeting. Here's another biomarker, the transglutaminase 2, is associated with good response to omalizumab. And possibly we need to look more on the total amount of biomarkers, for example, looking at the entire basophil proteome and not just focus on individual biomarkers. So I guess I'll give the word to Chris now.
This one is fixed, okay. Welcome. So we're going to talk about what to do with patients who do not respond to omalizumab. And of course, if you look at this, the EAACI algorithm for urticaria is a thing of beauty. It's simple, it's very comprehensive, it works in most patients, but of course, as I need to be controversial, well, it doesn't really work in everyone. So even though we have amazing drugs, between 60 and 90% of patients will respond to omalizumab, but 10% will not. And the question obviously is, what do we do now? So the algorithm from EAACI is very easy. The algorithm that we follow in London, excuse me, in our multidisciplinary urticaria clinic might give us a few answers, because we very often put emphasis on phenotype-driven treatment of urticaria. And when we move on, we'll find out that some of the older drugs might be very useful indeed. So there are 4 potential options, and of course it's a room full of experts, so I'm not going to say that everyone needs to review the diagnosis if there are any doubts. But then the question is, if omalizumab doesn't work, do we add cyclosporine to omalizumab, or do we replace omalizumab with cyclosporine? Or perhaps, if the local regulations allow us to do it, do we perhaps play with the dose or the interval of omalizumab? Or perhaps we go for something completely different. So it is extremely important to do it, because otherwise I think that's how I feel sometimes when omalizumab patients don't respond, and definitely our patients feel like this, because they say to us, you've given me this expensive, amazing drug, but it hasn't worked. So I say to them, let's think what we can do. So of course cyclosporine very often gets lots of bad press, but the reality is that if it is used in a sensible and cautious way, it might work in around 70% of patients. And what's even more important is there is some evidence that cyclosporine can indeed be a disease-modifying drug. Now you're going to see if I really know my presentation or not, because the slides have disappeared. So I can tell you, if somebody brings the presentation back up, is that in our experience we start usually at 4 milligrams per kilogram, then we reduce by 1 milligram every 6 weeks, and then we notice that in our patients there is an amazing response in those who are BHRA positive. So that's the first thing that I can say. If you are stuck with omalizumab non-responders, think about cyclosporine, perhaps think about using a biomarker called basophil histamine release assay. And of course there are side effects. There is no point pretending that it's a very gentle drug, but if it is done in a very sort of monitored way, usually the side effects are reversible, they are mild, and there is evidence from Israel where patients have been treated with low dose cyclosporine for up to 10 years without major side effects. Then if we move on, can we get the top bit of the presentation up? Because this is the bit that I feel very precious about, is because this is our experience at Guy's and St. Thomas's Hospital, where we combine omalizumab with immunosuppression, which you can't see, and we have 10 patients and 8 patients, 75% of them responded to a combination of omalizumab and cyclosporine. 2 patients responded only to oral steroids. There are 2 patients from Leeds, where again the combination of omalizumab and cyclosporine was very helpful. And there are a few other cases which are equally important, but they are not from our center. One of them that I wrote up with my colleagues, this was from Cambridge, where again combination of omalizumab and cyclosporine was very helpful. Is there any chance of bringing the top bit of the presentation? Well, again, trust me, the sort of the heading says what to do, can we play with omalizumab? And I was going to show you evidence from Leeds, from our colleagues in the United Kingdom, where they said that 85% of patients responded to a standard dose of omalizumab. However, 15% required a higher dose, a shorter interval, or perhaps both. And in their experience, and now you can see, in their experience patients were slightly heavier, they had a more severe form of urticaria and a higher level of IgE, and they were more likely to require higher doses of omalizumab, but this was not statistically significant. And there are, here it is. And then there are some other publications, including one by EMEC, that also talks about changing the dose, changing the interval. So there's the second option, immunosuppression with or without omalizumab in higher doses or given slightly more often. And this is a rather busy slide, but I think what's very exciting is that yes, first of all, the conflict sort of interest is that we do use these drugs. The evidence is not perfect. We cannot compete with omalizumab. We cannot compete with ligelizumab. And of course, very often it's series of case reports. But what about using other forms of immunosuppression, such as methotrexate, such as mycophenolate? What about using anti-inflammatories, dapsone, sulfasalazine? Hydroxychloroquine in some patients can work. Danazol, doxepin, so these are old drugs. However, they can very often help patients with chronic inducible urticaria where omalizumab has not been successful. And then we also have this exciting new chapter, which means all the new biologics coming onto the market, or biologics that already are available, but they are of course not licensed for urticaria. But there are ongoing studies looking at dupilumab, there are ongoing studies looking at anti-IL-5, and Simon's paper from a few years ago where they used anti-TNF blockers, and they had 7 omalizumab non-responders. 7 omalizumab non-responders treated with anti-TNF, 5 of them responded completely, 1 of them had a partial response, 1 of them did not have a response. Another therapy that perhaps one should not neglect is the phototherapy, and narrowband ultraviolet B phototherapy in our experience is very helpful when it comes to the management of symptomatic dermographism if we can't use omalizumab. Future is really exciting. There are plenty of new drugs on the horizon, but you'll be pleased to know that you don't have to listen to me talk about them because there is a wonderful presentation coming on Saturday, and that's where we're going to discuss all the details of new treatments. So this was a very sort of quick tour through what we can do to our omalizumab non-responders. And there is a question which I would like to ask, first of all, our speakers, our experts, and then perhaps the audience. So from your point of view, do you have a preferred option? What do you do if your patients do not respond to omalizumab? No, I was going, well, we can either ask the audience first, or we can find out what the experts say, but perhaps let's find out what the audience thinks, because we don't want to be persuaded by our experts to change our opinions. So what do you guys do? Which option do you go for? Right. So a very interesting combination. High doses of omalizumab, almost 50% of our colleagues. Immunosuppression with or without omalizumab, that's another exciting option. But let's see what our experts think. Could I ask for comments, please?
So such patients, my cocktail regime little difficult to digest, but what I do is, patient should be on 4 tablets of antihistaminics, 1 tablet of dapsone, with cyclosporine, with omalizumab, and weekly pulse of prednisolone. Saturday, Sunday, 30 mg of prednisolone. So with this kind of cocktail, toughest of tough patients, I am able to keep under control, and then I try to reduce the pulse steroid.
I think that when you point this question, the answer should be a little bit different if you are facing a patient which is a complete non-responder or a partial responder. And if you treat them after 3 months or 6 months, and you decide to stop or not stop. If it's a partial responder and the body mass index is high, or maybe it started immediately after the use of cyclosporine, probably we will need to updose the doses, but nobody is more than 600. And you will have maybe a complete response, and maybe not, and maybe you can add a little bit of cyclosporine. But if it's a complete non-responder, after 6 months, even if you updose the dose, then personally I change immediately to cyclosporine. And if the neutrophilic infiltrate is there, I will use dapsone, and that's it.
So I think, Anna, you said half of what I was going to say, but I think If you have a partial, modest response, the idea is that you need more of omalizumab, shortening the interval, raising the dose, echoing what Anna says. Looking at the patient phenotype, if they have other autoimmune features, you may select different drugs. I typically consider pursuing a biopsy before I put somebody on a significant prolonged immunosuppression. I will also typically not go a year to make the decision. I think, Anna, what you said, 3 to 6 months is a reasonable trial before you move on to another dose. So I actually would have probably clicked on all of the above. It really depends on the clinical response pattern and phenotype.
Okay, I think that the point is clear. There's a big difference between totally unresponders and partial. 10–15% are totally unresponsive partial. When they are partially non-responders, then obviously the question is right, you can updose, and usually they can benefit from updosing. In my experience with more again than 300 patients, the 10% who were totally non-responders did not benefit from uprising the dosage. And in this case, the two options is either cyclosporine A or a combination with OMA and cyclosporine A.
So I agree with Anna totally, but another question is, when you say non-responder, when did you decide that? So some patients may not respond at all for the first injection, but some patients may respond after, say, 3 injections. I agree with Romy that 3 months injection observation is reasonable time.
One thing to consider are obviously differences between different countries, because of course updosing is a very exciting concept. However, according to the British guidelines, unfortunately, we are usually forbidden from increasing the dose or shortening the interval. So I couldn't agree more. Of course, I would love to give my patients 600 before I think about giving them something else, but this is not usually what's allowed. And I think that's what's so exciting about this meeting, that we can compare practices across the world, where in some places there is more flexibility and more ease when it comes to using higher doses. However, in the UK, the rules are extremely tight, and if patients end up on a higher dose, it's usually an individual funding request. And biopsy and reviewing the diagnosis, this is something that we would always pursue if we are stuck, because it's very easy to get completely blinkered and assume it is urticaria, because that's what we've always been treating, but actually perhaps it is not. Happens very rarely, but we would sort of test our own diagnosis.
And also, I'd like to say, the subtype of urticaria, we don't know about the efficacy of omalizumab for different subtypes of urticaria. The literature says that seems to be, so it seems to require less amount of OMA, but we don't know how individual subtype of urticaria are responsive to omalizumab. I have a personal experience that, well, some patients did not respond to omalizumab at all, but the diagnosis is not CSU, that was cholinergic urticaria. So we should think about the efficacy of omalizumab for individual subtype of urticaria as well.
Chris, you've opened up combinations of treatment with omalizumab in addition to antihistamine, of course, and you've mentioned cyclosporin, and I think that is real. We have seen good results. Do you think there are any combinations that should not be used? Could we use dapsone? Could we use hydroxychloroquine with omalizumab? Do you know anything, any data that says this would be a good idea?
In our experience, we've used cyclosporin the most often because we are really familiar with it. There were 1 or 2 patients on oral or subcutaneous methotrexate in addition to omalizumab. There is 1 patient on dapsone and omalizumab, but these are the most complex cases, so those are exceptional cases. Some of the American data around, I think, 17 patients treated with immunosuppression, and again, cyclosporin was very often used. So I think we would be willing to explore it. And the next thing is, can we combine other biologics with omalizumab? This is the question we get asked very often. Patients who go on dupilumab for eczema, perhaps with omalizumab, or perhaps dupilumab on its own, or patients who end up on biologics for the difficult eosinophilic asthma, who at the same time have difficult urticaria, where we are about to have a patient who might be on mepolizumab and omalizumab for 2 different conditions. So I don't think that there's a contraindication to mixing different ones, but it all requires very close monitoring. I think we're very mindful of time and we don't want to delay our colleagues, so thank you very much from Simon and me. Thank you.